40-year-old man came for cardiac evaluation because of abnormal ECG. Cardiac magnetic resonance sequences showing multiple myocardial defects or invagination in the ventricular septum suggestive of non-compactation aspects. Analyzing the image, we have two diagnostic hypotheses. Myocardial crypts or clefts are narrow and deep load-filled invagination contiguous with the left ventricular cavity, extending greater than 50% of wall thickness, that are not associated with any outpunching of the myocardium and that are associated with the normal contractive function. Single pair clefts have been observed in the ventricular septum and the basal inferior wall of the left ventricle in healthy volunteers, but the presence of multiple clefts although a rare condition is often associated with the hypertrophic cardiomyopathy phenotype. Indeed, they have been identified as a potential novel cardiovascular magnetic resonance imaging marker for genotype positive status in the absence of the left ventricle hypertrophic. The second diagnostic hypothesis was multiple muscular ventricular septal defects. Muscular or trabecular ventricular septal defects are divided in posterior muscular defects in the inlet area of the muscular septum, anterior muscular defects, mid-muscular defects that are proximal to the moderator band, and the apical defects that are below the moderator band in the ventricular apex. We define Switch's septum as multiple ventricular septal defects involving all components of the septum and/or morphologic characteristics suggestive of non-compactation. Frequently, spontaneous closure of a small muscular ventricular septal defects occurs in the first 2 years of life. Cardiac magnetic resonance with its high spatial resolution and sharp contrast between the blood and the myocardium provides a unique opportunity to characterize left ventricle morphology. Particularly, this technique is well suited for the examination of ventricular septal defects because it can accurately quantify shunt volume and the effect of the shunt on left ventricle and right ventricle structure and function. The steady-state free precession sinus sequences in long and short axis stacks are the relevant sequences to study this pathology. In this video, we can see 4 chambers view, 2 chambers view, and China short axis view, and we can identify the defect of the septum at mid-ventricular and apical level. We don't see the dilation of the right ventricle or the evidence of a presence of a direct jet from left to right ventricle. These elements make the differential diagnosis more difficult. In general, when we suspect a crypt, an essential issue should be defined a priori, the location of multiple crypts. Indeed, these findings are usually seen in the lateral and inferior wall, marked trabeculation and left ventricle non-compactation. So, it is useful to differentiate from spontaneously closed ventricular septal defect. The best way to determine the presence of a significant shunt is by calculating the QP/QS using the aortic and pulmonary artery flows. Phase contrast images are obtained perpendicular to aorta just distal to the aortic valve and the pulmonary artery just distal to the pulmonic valve. In this case, the patient had a QP/QS ratio less than 1.5. Another important characteristic of cardiomyopathy is the presence of late gadolinium enhancement (LGE) that indicates the myocardial fibrosis, and this is typical characteristic of a hypertrophic cardiomyopathy. We use inversion recovery fast gradient echo for the LGE assessment, and this technique is an important non-invasive imaging method that can detect the presence and extension of localized myocardial fibrosis. This patient doesn't have any LGA pattern, as we can see from these images. For all these reasons, we concluded that the patient has multiple interventricular septal defects spontaneously closed. This diagnosis will require close follow-up and subsequent cardiological checks.